Good morning. Welcome to our online event, Psilocybin Therapy for Depression in PD. Today's program is brought to you by Parkinson's Community Los Angeles. Today we are so fortunate to have with us Dr. Ellen Bradley. I'm Angela Neff, PCLA board member. For those who don't know us, we are a nonprofit that supports families living with Parkinson's through free education programs like this one, online and in-person support groups, social events, and much, much more. Today's conversation is brought to you by our generous sponsors, Acadia and Boston Scientific, and by important donations from people just like you and me in the Parkinson's community. If you appreciate our work, please consider making a donation at pcla.org. Your donation is 100% tax deductible, so thank you in advance. We rely on your generosity to help us continue this incredibly important work. Please join me in welcoming Dr. Ellen Bradley, MD. She is currently an Assistant Professor of Psychiatry at UCSF Weill Institute for Neurosciences. She's researching the effect of oral psilocybin therapy for depression and anxiety, motor symptoms, and people with Parkinson's. I am very excited about this. Welcome, Ellen.
Thank you. Thanks so much for that intro, Angela. And thanks to Judy and the rest of the PCLA team. It's really nice to be here. I appreciate y'all giving me the chance to speak with the group. And yeah, I hope this is a helpful talk for y'all. I'll do some background and talk about this research and then hope to leave lots of time for questions and conversation afterwards. So like Angela said, I'm a medical doctor trained in psychiatry, and I split my time between, doing this research at UCSF, focused on psychedelics, and then also serving as an embedded psychiatrist at the San Francisco VA in the Parkinson's clinic there. And I've learned a ton about PD, mostly from folks actually living with the illness. And so really happy to talk to you about this particular area of work, which is close to my heart. I'm sure that everyone here is very familiar with this analogy, this idea that PD is kind of like an iceberg. There's this part above the water that most people who don't know that much about PD even know about: the slow movements, the tremor, the rigidity, the whole set of motor symptoms that are quite visible. But then there's this kind of bigger part that's under the water, harder to see, all of these other issues that come with PD that are often hidden. Because the degenerative process, it impacts so much circuitry in the brain. Really, we're thinking more and more, we shouldn't be thinking of PD as just a movement disorder, but should be really thinking of it as more of a complex neuropsychiatric disorder. And depression is one of these problems, kind of under the water that we often miss. I think sometimes it's one of the issues that we as doctors or other providers, it's like the last thing we ask patients about. And that really shouldn't be the case because depression it's so common in PD. We think it affects probably up to half of people who are living with PD. And it's very impactful. It's associated with having a faster cognitive and physical decline. It's a very strong predictor of people's quality of life, even more so than, how severe their motor symptoms are. And it's undertreated, partly because, like I said, we often don't ask about it. We maybe don't recognize it. But we also are lacking treatments that work for everybody. I think that, one of the reasons that depression has been kind of under-researched in PD is because we may have underestimated it a while back. I think, folks used to think of depression in PD as kind of a psychological reaction to having a difficult disease, which of course is a very intuitive explanation. I think we can all relate to that idea that when one is living with a really difficult chronic illness, that is depressing. And it's not that that isn't true, but now we have learned that depression may actually be part of PD itself, so part of the pathophysiology of the illness. What might, play a role in creating depression and PD? The short answer is we don't really know yet, but there are a few hypotheses about, mechanisms by which the degenerative process in PD might impact our mood. The first thing is, we know that there is this imbalance of monoamines in PD. Those are the chemical compounds that act as neurotransmitters in our brain. So that's, of course, dopamine, but also serotonin, norepinephrine. There's also this decrease in what we call trophic factors. These are the proteins that are super important for stimulating growth and survival of our cells. So they're very critical for brain health. And we know that those are decreased in PD and that may relate to changes in mood. There's also dysregulation of the hypothalamic pituitary adrenal axis. So that's a hormonal communication system that is really important for regulating our body's responses to stress. Also can play a role in our mood. Brain inflammation, of course, plays a really important role in neurodegeneration and PD specifically, and has been linked to mood changes. And then the last thing is this idea of oxidative stress. So that's an imbalance between these unstable molecules, free radicals, and then these neuroprotective antioxidants in our brains that can harm cells when they're imbalanced, when there's too many of those unstable molecules. And that imbalance can make our mitochondria less effective at meeting our body's energy needs. And again, this is something that we see in PD, and it's possible that this could be also related to depression. So we don't know yet if, one of these or all of these mechanisms might be related to depression and PD, but I just bring it up because I think it's important to realize that there may be quite complex reasons for the depression that we see in PD, and an explanation for this may provide an explanation for why depression is so common. Okay, so let's go on to what do we do? What do we do about the depression that we do see when patients come to clinic? This is important to go over, I think, before we get into talking about, psychedelics, new treatments. Well, this is what we currently do. These are kind of the current best strategies for treating depression in Parkinson's. And I kind of think of these like 3 prongs of treatment, and, it's possible to use them all together. The first one is what we call behavioral activation. So this is the idea that, there's a vicious cycle of kind of inactivity, withdrawal, and isolation that can really contribute, kind of feed depression. And if we can break that cycle by gradually helping people increase their activity, that helps to regain a sense of self-efficacy, improved outlook, and kind of creates a virtuous cycle that makes people feel much better in terms of their mood. The second prong is cognitive behavioral therapy. This is a type of manualized talk therapy that's based on the idea that unhelpful ways of thinking can contribute to having poor coping and impaired mood and function. And so in CBT, we work to change those unhelpful patterns of thinking through training, kind of like, just like when you go to PT, you're kind of trying to train your muscles into a better type of functioning. And the same is true with like these patterns of cognition. So helping us get out of some ruts and trying to kind of pave new, better roads in terms of our thinking. And then, of course, the last piece is medication changes. And there are quite a few medications that folks use to treat depression and PD today. And, those are usually the same medications that we use to treat depression outside of PD. So antidepressants like selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors. And I think that it's important to recognize that, for a lot of folks, these treatments work quite well. And that's great. These are great strategies for a lot of people who are living with PD depression. But they definitely don't work for everyone. And that's how we got here. A few years ago, our team at UCSF, we're a multidisciplinary group that does psychedelic research, and we started asking this question, wondering about this. Could psilocybin therapy improve depression in PD? Could this be a new treatment? There has been evidence, there's been some studies that psilocybin therapy could help with depression among people without PD. So that's kind of where the idea came from. But there hadn't been any work in folks with PD or any neurodegenerative disease at all. Folks with neurodegenerative illness had actually been excluded from any research at that point. And so we really didn't know anything. It was kind of uncharted territory. Before we get into any more about the research, let's just talk about psilocybin for a second. As you probably know, especially if you decided to come to this talk, psilocybin is the active ingredient in hallucinogenic mushrooms. It is found in many, many species of mushrooms that grow all over the world. And of course, the idea of humans consuming psilocybin mushrooms is not at all new. You see on the left, there's a mushroom statue from 1500 BCE that it was found in what is now the Guatemala. Mushrooms have been used in traditional healing practices and ceremonies by humans for a long, long time. But more recently, there's been this broader interest in how psilocybin and other psychedelics could be used to promote health and well-being, and be used actually in the mainstream healthcare system. And I mean, a lot of that I think we can attribute to Michael Pollan's book that came out in 2018. Many people read this book. It got a lot of people kind of interested and excited in psilocybin and other psychedelics. One of the first questions that people usually ask us when they're thinking about participating in a study is, what does psilocybin feel like? What is the experience like? When you ingest psilocybin, it starts to have effects in about 20 minutes, and the acute effects last usually about 6 hours. And the answer to the question of what does it feel like is, the short answer is it really depends. The effects that people feel right after they take psilocybin depend on two things, on the dose and then also on the context. So for instance, if you take a low dose of psilocybin, people might report feeling more alert or stimulated than usual. They might have the sensation that colors are a little bit bolder and brighter. Some people say they feel like subtle changes in their thought patterns. Whereas with a high dose, people can have very vivid hallucinations. People can have experience synesthesia. So it's like feeling like you can, smell a color. They can also experience intense mood changes. People can feel very euphoric. People can also feel quite anxious. People often report feeling as though they have left their bodies, and sometimes a feeling of wonder or awe about the universe and a sense of unity. There's a lot of variability in these experiences, individual to individual, and even session to session. And then the context piece, these effects also really depend on context. And what I mean by that is really the psychological and the physical space where people are taking psilocybin. So the mindset that someone comes in with going into the experience, so how prepared they feel, what they're trying to get out of the experience. And then the setting, the place where they take it. It can be an extremely different experience if one uses psilocybin at a loud, chaotic music festival versus in a quiet space with a provider present with them. So psilocybin therapy has really been designed with that importance of context in mind. I want to emphasize that psilocybin therapy, this is not the this is not the only way, of course, that one can use psilocybin. I'm focusing on it because it's, it's what we use in our studies currently. At this point, this is the best studied model, particularly for trying to treat depression. So all of the research that's been done on the use of psilocybin for depression has used this basic model of a combined treatment. So the drug, the psilocybin, is only taken usually once or twice. So these like single doses, not like a medication you take every day. And then there's talk therapy sessions that happen both before and after people actually take the drug. So I'll just walk through how we have implemented psilocybin therapy in our group. The first step, like I said, we start with the talk therapy piece. We call this first part preparation. The patient meets with one of our therapists. We can usually do this on Zoom. And the goal of these preparation sessions is really to kind of get some background on the patient's history, what they are hoping to get out of the treatment. It's also an opportunity to talk about, what the psilocybin session might be like and to answer any questions that patients have. And then there's the psilocybin session itself. And for that, we have patients come to our research unit at UCSF, where we have this private space that pictured here that's reserved for these sessions. And there they meet their therapist in person. One of me or the other physicians is on site, and they take the psilocybin here in that room. And as you can see in the picture, we usually encourage folks to lie down. We have eye shades available. We have music available to try to really direct their experience inward. And their therapist stays there throughout this whole session, checking in, of course, checking vital signs, monitoring safety, and then also offering any psychological support that patients want through the experience. And then afterwards, more of these talk therapy sessions. We always do a couple after the session, and we call these integration because this is really, the focus here is really about trying to help a patient make sense of the experience that they had when they took the psilocybin. What came up during that experience? How are they kind of making sense of it? How does someone want to try to carry forward aspects of that experience into their life? Quite a few studies in the past few years have evaluated, if psilocybin therapy is an effective treatment for depression. These are not studies in PD. These are studies enrolling folks who have depression, but are medically healthy. And I won't go through all these studies, but I just wanted to highlight a couple of key findings that are nicely illustrated from this trial. This is a trial that was sponsored by the USONA Institute, and this paper was published in 2023. And in this figure, what we're seeing is along the horizontal axis, the x-axis, we have days. This is like time since psilocybin. And then on the vertical axis, the y-axis, is the change in depression. So lower down on the axis is less depression. So that's the direction of improvement. And I just want to point out some interesting things about this. So the little blue triangle is showing where these participants received the psilocybin. Okay, so that's like the point in time where they had, in this case, they had one session of psilocybin. And then some interesting things to notice. First of all, so this in the blue box, I'm highlighting the difference between the group that got psilocybin versus the group that got placebo at 8 days after psilocybin. This is fast. Usually when we treat depression, as folks here may know, it's usually a process that takes weeks to months. Most of the treatments that we have depression, they just take quite a bit of time to work. So this is interesting because this is just much faster than what we're used to. And then the other thing to notice is as time goes on, they followed folks in this study out to 43 days after they had received the psilocybin. And we still see this big difference between the people that got placebo versus the people that got the psilocybin, the active treatment. And that's interesting because it's been 43 days since they had exposure to the drug. And that is also kind of new for us, right? Because if we're doing medical treatment of depression, we're usually talking about drugs that people take every day to maintain an effect. That's true of most medications, right? This is unusual that even though people are so far out from their exposure to the treatment, they're still feeling better. Okay, so why do we think that psilocybin therapy has these kind of unique effects on depression? We don't know. A lot of people are trying to work to understand the mechanisms of this treatment. We don't know. There are quite a few hypotheses out there. I'm just going to highlight a couple of ones that I think are particularly interesting when we're thinking about PD. This is a hypothesis that's gained a fair amount of support. This idea that psilocybin is what's called a psychoplastogen. That's a term coined by David Olson and his team at UC Davis. And a psychoplastogen is a molecule that produces a rapid and sustained change in the structure and the function of neurons. So that's illustrated here. This is an illustration showing like this working model, this idea that a psychedelic like psilocybin, psilocin is the active metabolite of psilocybin. That's what's shown here. And the idea is that the psychedelic induces this burst of growth in the dendrites on a neuron that increases the availability of synaptic connections, so the connections between neurons. And then from there can be a new pruning process, the natural pruning process in the brain that can essentially remodel connections in the brain. And so one hypothesis is that this induction of brain plasticity can help to open a window of kind of adaptive learning that helps people really change maladaptive patterns of thinking and behavior, the things that maintain depression. Related to that is the idea that psilocybin has these anti-inflammatory actions, which has been shown in preclinical models, so in rodents and mice and rats. And that's interesting because, if we think about, we know that inflammation may be a contributor to depression. And in this figure, what we're seeing is like on the left is a kind of showing what's happening with the immune system in a heightened inflammatory state, which, we know we have in PD. The breakdown of the blood-brain barrier, this kind of abnormal upregulation of these inflammatory factors in the body. And what we're seeing here is that, again, like psychedelics, psilocybin, and others seem to have the ability to come in and help downregulate those pro-inflammatory proteins and upregulate anti-inflammatory factors and factors that are protective to nerve cells. And so this has raised the question, is it possible that psilocybin could have a neuroprotective effect in humans? And is that related to its effects on depression? Sounds pretty great. So why don't we just give psilocybin to everyone? This is a really important issue because I think there's a lot of positive information about psychedelics out there right now, a lot of positive media reports. And I think it's really important to remember that, drugs that affect our brains are always complicated, and they're always really important safety risks to think about. I want to highlight a few here that are most relevant for PD. The first thing is that, of course, people with PD often experience hallucinations, other perceptual disturbances that can be really distressing, that can be really impairing. Is it safe to give a drug like psilocybin that that itself causes hallucinations to people whose brains may be more vulnerable to those kinds of disturbances? We don't know. This was a key question that we had going into this research. A key safety question. Is there a chance that we could make those symptoms worse if we give people psilocybin? Another safety concern that we have had is related to the autonomic dysfunction in PD, right? So people with PD are experiencing changes in the nervous system that's making it harder to regulate blood pressure and heart rate. Psilocybin it's a sympathomimetic drug, so it activates our sympathetic nervous system. So it does cause these transient increases in blood pressure and in heart rate. Is that going to be safe for folks with this underlying autonomic dysfunction? And then the last issue is medications. Of course, most people with PD are using dopamine replacing medications usually throughout the day to address motor symptoms. And we're still really early on in our understanding of how psilocybin interacts with different classes of medications. So another place where we have to be really mindful. So given all of this, a couple of years ago, our first step as researchers was to do this, what we'd call it, a first in human study, a small study that's really just focused on safety to try to answer the question, is it even reasonable for us to explore the use of psilocybin for depression in PD? Is this a good idea? So what we did is we enrolled 12 people with early to moderate stage PD. Folks ranged from 45 to 74 years old. And we used the combined drug and psychotherapy approach that I mentioned before, this psilocybin therapy approach with the preparation psilocybin sessions. In this study, we did 2 psilocybin sessions. People had 2 sessions at different doses. And then the integration sessions. And then we had several follow-up visits after that to see how folks did. These are the most important data from the study, because like I said, really our main goal was to look at safety and tolerability. So what we found was that, first of all, really important that all 12 of the people who enrolled in the study were able to complete the whole protocol. I mean, they were able to complete both psilocybin sessions. We anticipated that some people might not respond well, and that if that was the case, we would, of course, stop their participation. We did not have to do that. Everyone was able to complete the protocol, which is great news. We also did not see any serious adverse events. Serious adverse events are, this category of negative outcomes that are really red flags for us. Like if people get really sick after an intervention, if they have to be hospitalized, things that would really make us worry, this is not necessarily a good direction. This may not be safe. We did not see serious adverse events, which is great. The most common adverse events were pretty similar to what we've seen in studies of psilocybin therapy outside of PD. So those were the elevations in blood pressure and heart rate that I mentioned, but those resolved within hours. People also experienced transient nausea, anxiety, and headache. Those are kind of the most common things that happen. We did not need to use any emergency medications. We always have medications on hand if there are any negative effects of psilocybin during the session. We did not need to use those to manage either these changes in blood pressure or heart rate or any other issues that came up. We also did not see worsening of people's perceptual disturbances or other psychotic symptoms. Again, that's a really positive sign because that's something that we were quite worried about. The folks in this study, 9 people in this study of the 12 were using levodopa. And we had those people continue on their existing regimen of Sinemet, including on the days when they took the psilocybin, and that they did quite well. That was great to see that we didn't see anything that would make us really worried about the interaction between psilocybin and levodopa. And we asked people about their opinions about this treatment, their experience in the study, and people reported a really high rate of satisfaction, both participants as well as their care partners, which was very encouraging. So what else did we see in this pilot? Like I said, the main goal was safety, but of course we also looked at changes in people's symptoms as well. And I'll just share the really key pieces. We did find that participants had significantly less depression after psilocybin therapy. So that's obviously really positive. That's the main thing that we are interested in terms of psilocybin's potential as a new treatment. We also found that people reported that they had better motor function, which was pretty surprising to us. That's not something we set out to focus on. But it's interesting. We're not sure if it is related to the change in depression or if it's a separate effect. It's something that we're going to investigate further. And then kind of like, that figure I showed before, we saw, as others have, that these effects lasted for weeks after people took psilocybin. So that was really interesting. We did the follow-up assessments on folks for a month after they had their last exposure to psilocybin. And their depression, we followed up again at 3 months, and it was still significantly lower than it had been at baseline. Okay. The last piece of data I want to highlight from this pilot study is the participant satisfaction data, because I think it gets at something that is kind of quite complex about psilocybin therapy. So the questions we asked folks about their satisfaction with the treatment were, pretty standard questions like, would you recommend this to other folks with PD? Did you find it useful or helpful? Did you find it acceptable? Like, kind of, was it feasible for you to do? And as you can see from this figure, just about everyone really agreed that they would recommend it, and they were satisfied with it in this study. But the last question we asked people is if they found the treatment challenging. And this is interesting because you can see here that most people, even though they felt positively about this treatment, they also felt it was challenging. And that is not uncommon with psilocybin therapy. It can be quite a complex and intense experience for people. And I highlight that again because there can be so much positive information about psychedelics in the media, but it has very complex and mixed effects, and we actually don't think it is necessarily, a treatment fit for everyone. Like most of our treatments in medicine, right, are not a good fit for everyone all the time. We don't really expect that to be true, but just to illustrate what I mean, a couple of comments from, even from the folks who in this category, this darkest blue color, these are the folks who strongly agreed that this treatment was challenging. One person who thought it was really challenging also had a very positive experience. He said, "My soul-crushing fatigue is gone. I never thought life with Parkinson's could get so much better," despite the fact that he found the treatment as challenging as he did. But another patient who also said, "Hey, this was a really challenging thing to get through," said, "Psilocybin blew the lid off my denial, and I was not ready for that." He found it quite challenging, even after the fact, to kind of integrate what had happened during the session and how he was feeling. So I just think it's important to kind of highlight how the diversity of experiences and the fact that psilocybin and other psychedelic treatments have a lot of complexity to them that I think sometimes gets glossed over a bit. Okay, so what do we do now? So overall, results of that pilot study were really exciting for the team, and we're really excited to continue this work based on the kind of like green light that we got from that pilot study. Of course, a 12-person pilot study is very small. So we went out and raised funding for a much larger trial so that we can get a lot more information about the safety and efficacy of psilocybin for depression in PD. That trial is now open. We are hoping that this trial is also going to help us explore what might be changing in the brain with psilocybin therapy so that we can understand more about its mechanisms of action, which we think is really important. And that may help us understand the action of other psychedelics, psychedelics that already exist that we might be familiar with, as well as, you know, these second generation psychedelics that people are working on developing. Okay, I want to go over just some key inclusion and exclusion criteria about the study and some frequently asked questions, and then I'll actually stop and we can go over questions from this group and have a discussion. But just to highlight, you know, like any trial, there's a whole list of inclusion and exclusion criteria, and most of these are about, you know, we're still very early in this research, so most of this is about really making sure that we keep people safe. We don't want to enroll anyone in this trial if we don't think that it will be safe for them to participate. We know that there's risk involved, and that's super important. So the folks that we are looking for in this trial, anyone aged 40 to 80 who has a neurologist diagnosed PD. Folks do have to have current depression. They have to be able to come to our space at UCSF at Mission Bay. That's where we do the psilocybin sessions and a lot of our assessments for the study. And they have to be able to participate in psychotherapy sessions. That doesn't mean that you have to know anything about psychotherapy or have experience with any kind of talk therapy. Plenty of folks in our studies have never talked to a therapist, and that's totally fine. You just have to be kind of willing and able to engage with our therapists. Things that are excluded in this trial. So severe psychotic symptoms, because we are still worried about that potential risk, and we don't want to enroll folks who are experiencing severe psychotic symptoms. We also don't want to enroll folks who meet criteria for dementia because we're not sure if that is going to be safe cognitively. Certain very serious cardiovascular problems, like something like a recent heart attack, would probably be an issue because, again, because psilocybin has those effects on blood pressure and heart rate, we just want to be careful and not enroll anyone who might be at greater risk of a bad outcome. And then, you know, medications, there is like a list of medications that we think are worrisome to combine with psilocybin. So we, you know, go through a medication list with everyone who comes and expresses interest in the study, and really try to understand, you know, what the risk profile is. Often we can kind of work around problematic medications. Sometimes there are things that folks can stop temporarily so they don't interact with the psilocybin. We kind of work with people on a case-by-case basis. But there are certain medications that if they're absolutely required, you can't take a break from them, they're not going to be safe to combine with psilocybin. Okay, and then lastly, I thought we'd just cover some of, these are probably the questions that we get asked the most so far, but yeah, I'm curious to hear what questions this group has. But I'll just run through these. The first question is, folks ask if they need a formal diagnosis of depression to participate, like a diagnosis from a psychiatrist. The answer is no, certainly not. If you are currently experiencing depression, what we do is we evaluate folks' depression. So we'll ask you, you know, a series of questions to understand if you meet criteria currently for depression, but you don't have to have a formal diagnosis. Many folks come to us, they say, I have PD, but I'm not depressed. Can I still participate? Not in this study. Currently, we're focused on treating depression. So folks do have to have depression as well as PD in order to be in this study. Is it possible to get a placebo instead of psilocybin? So I showed that data from that study that had a psilocybin compared to a niacin placebo. The study has a different design. So the answer is no. In this study, all participants will receive psilocybin. They will receive 2 sessions of psilocybin, and the dose in each of those sessions can range from low to high. So you may get a different dose of psilocybin, may get a lower one or higher one, but everyone gets psilocybin. Will I eat mushrooms in the study? No, there are no mushrooms, even though psilocybin does come from mushrooms. We use a pharmaceutical grade, synthetic, pure psilocybin that is manufactured and meets certain criteria, the same criteria that like pharmaceutical grade medications have to meet. Can I participate if I have other health issues aside from PD? Absolutely. We understand, of course, people have often living with many other health issues. Again, we go over this during screening, ask people a lot about their health history. There are certain health issues that would make it unsafe to participate, but kind of like with the medications, we really evaluate those on a case-by-case basis. So we encourage people to come and talk to us about what's going on with their health, and we'll figure it out. So aside from the treatment, aside from the psilocybin therapy itself, what else will I do as part of the study? The study does involve, quite a few assessments. Like I said, we're hoping to not only understand whether psilocybin therapy is effective for depression, but we're also hoping to understand how it affects PD symptoms more broadly. So there's assessments of PD symptoms, comprehensive assessments, and we're also hoping to understand more about how it works. So the study includes brain imaging, as well as blood-based biomarker evaluations. And lastly, who is paying for this study? It's always an important question. This study is funded by philanthropic donations to research at UCSF, and specifically to PD psychedelic research. It is not an industry study. All right, and with that, I will just say that I'll open up for questions, but I want to just emphasize that there's so much about psilocybin and other psychedelics that we really don't know yet. We're very much exploring uncharted territory and trying to understand how these drugs might be able to improve life for people with PD. That is impossible to do without the PD community. So thank you so much for partnering with us on this work. Whether that means you enroll in a study or are raising money for research or just spreading the word by talking to friends and family about this work, we so appreciate you joining the effort. It makes a huge difference. This is our multidisciplinary team and our supporters. Just a shout out to our whole wonderful team, which makes all this research happen. Thank you so much. And I'll put this back up so folks can see the contact information. Okay.
Thank you, Ellen. That was wonderful, so thorough. Let's see what we have for questions. The first one was mescaline never considered instead of psilocybin.
Mescaline instead of psilocybin? Yeah, it's a really interesting idea. I think there's a lot of different psychedelic drugs that we can explore for PD. We decided to start with psilocybin because it is by far the best studied so far, has the most safety data by a long shot. But I think in the next few years, we're hoping to expand and look at other compounds as well. And I'm sure that other groups will too. So we're excited about that possibility.
Great. Somebody else was interested in knowing what the doses were.
Yeah.
In this.
So the doses in this study can range from quite low, like what people might call a microdose, so something that doesn't create strong subjective effects, to quite high, a full like psychedelic dose. So the highest dose is a dose that does induce a pretty strong subjective effect in most people, meaning like, the visual, the perceptual changes, changes in mood and cognition. Um, it's difficult to sometimes folks ask what the kind of dose would be in mushrooms, which is very hard to estimate. So the highest possible dose in this study is 25 milligrams of psilocybin, which has been used in several studies for depression in the past. 25 milligrams of psilocybin, I have heard people say it's equivalent to approximately between 4 and 6 grams of psilocybin mushrooms, which is a huge range, but that's because, mushrooms range dramatically in their potency in terms of how much psilocybin they contain. So I hope that gives a sense.
Absolutely, thank you.
Sure.
Um, are there studies done with people with Parkinson's experiencing olfactory hallucinations with, I don't know this word, hyposmia? Hyposmia?
Hyposmia. Yeah.
Hyposmia.
Yeah, that's a great question. I mean, our study is the only ones that I know of that are examining the effects of psilocybin and PD at all. So we have had, we did have some people in the pilot who experience olfactory hallucinations, like at baseline. And I anticipate that, we'll have folks in this new trial who have those experiences. We don't exclude people just because they have those perceptual changes like olfactory hallucinations. It's only if the psychosis is quite severe that we exclude folks because of safety.
Okay. How many in-person visits are required to participate?
There's 2 psilocybin sessions, so those are the kind of the longest in-person visits because they're usually the better part of a day. But then there are also let's see, there are half a dozen um, in-person visits over the course of the first 3 months, and then a 3-month follow-up visit after that at UCSF. Yeah, so they're kind of spaced out. Yeah.
Nice.
Mhm. And some are shorter,
Uh,
some are longer.
and this is a bit of an aside. If somebody has done psilocybin with a guide before years ago, would they still qualify for this?
Yeah, oh, that's a great question. Yeah, we that's totally fine if folks have previous psychedelic experience. We just ask that people haven't had recent use, so in the past 6 months, haven't used any psychedelics.
Um, I was really, next question, I was so impressed with the improvement in depression. Like you said, it was just incredible.
Yeah,
Um, Somebody's asking here about if you can expand on the improvement seen in extraordinary lethargy, because there was that one of the guys talked about how much it helped that. Um, but yes, if there's anything else you can say about the improvements in lethargy, which I think so many of us with Parkinson's experience.
absolutely. Yeah, I don't know. I don't know how to interpret that. Is it that so fatigue is often a big part of depression, right? And sometimes when we effectively treat depression, people's fatigue gets dramatically better. Is that why that patient's fatigue got so much better, or is it a separate process? We don't know. That's one of the reasons why, in this study, we do have quite a few assessments because we want to capture both, depressive symptoms, but also symptoms of PD that, might overlap with depression, but they may also be distinct, like fatigue. So we're going to try to, disentangle that, but I really don't know.
Apathy comes up a lot in our support groups. It's a
Yeah,
huge part of Parkinson's. It's not talked about or understood that well. Um, I wonder, it would be very interesting to know what the impact on apathy it would have as well.
absolutely. Yeah. And apathy can be, it can be so hard to disentangle that from depression too, right? Sometimes we find that folks come to the study and they they have been kind of diagnosed with apathy, but not depression. But when we evaluate them, we find, oh, hey, you do actually, meet criteria for depression as well. It can be very difficult to, kind of draw a line between those things. But it's again, that's something that we're going to try to explore in this study. Definitely effects on apathy.
Um, can the therapy sessions be done over Zoom or are they held in person
The
as
therapy
well?
sessions are all done over Zoom. Yeah. Yeah, we have them on Zoom for that to try to, make the study as accessible as possible, so that folks don't have to do too many in-person visits. Yeah.
You mail them the drugs
Oh no, the
or what?
psilocybin is always in person. The drugs cannot be these drugs are still, they're um they're very highly regulated. You cannot prescribe them as a doctor. You cannot send them to people. You can't even, I mean, there isn't a way for anyone to go and get psilocybin therapy treatment as part of like regular medical care. Right now, it's something that you can only access through participation in a clinical trial because of those regulations. So
That
no, we
makes sense.
always give the psilocybin only at UCSF in our research unit at those specific sessions.
Some PD patients have dementia-like symptoms, such as impacted spatial awareness. Would this preclude participation?
So a diagnosis of dementia, yes, that does preclude participation. But many folks in our studies have, some degree of cognitive dysfunction, some issues, and that is fine. We do an evaluation, we do a cognitive evaluation as part of the screening to kind of understand where folks are at. So yeah, we will check that out. But I would say for people who don't have a diagnosis of dementia, I'd encourage them to fill out the survey, to apply if they're interested. Yeah.
How do you approach patients who are already taking antidepressant medications? Will they need to wean off of these?
Not for almost all antidepressants. In this study, we are having folks, for the most part, to continue their treatment regimen if they want. If folks want to taper off, they can, but we're not requiring it. We only are requiring it for, there's a few medications where, like I said, we'd be worried about the safety of mixing it with psilocybin. And in those cases, we will ask folks to taper off. But that's not true of most antidepressants. So they should be fine. Yeah.
Um, are there doctors administering this type of therapy in Los Angeles, or is it not approved for
It is not
Parkinson's?
approved. It is not available as a clinical treatment anywhere. It is accessed only at this point through research studies. Um, I don't know of any research studies that are enrolling folks with PD in Southern California. Ours is the only one that I know of, but it is possible, of course, that there could be one in the future.
How many in-person visits are required to participate? You did, not sure what the number is, but you did have a slide that covered that.
So I would say that we do have folks who come from out of town to participate in the study. If people are interested, when there's like a pre-screen, a survey that you fill out online, and that survey has much more detailed information about the visits, and And if you complete the survey and move forward, also our study coordinators kind of go over the details of the schedule and try to help folks work out, a travel plan that makes sense, that's not going to be too burdensome. We've tried to design the study so that it's not too burdensome, so that folks could maybe come to San Francisco for just a couple of, probably, a handful of trips over a few months. And so for many folks that's been manageable, but we understand that travel is tough. We will definitely work with people to try to see if we can, accommodate different needs as much as possible. But it is not a remote study. It's not the kind of study where we could mail the drug and just do it all over Zoom. No.
Okay. I thought this was a great question. How does a drug that produces hallucinations treat people with Parkinson's that experience hallucinations?
Great question. Like I said, that was one of the things that we were really worried about, when we did the pilot. We were like, is this going to make people's hallucinations worse? And that is why we're, limiting enrollment still, even after the pilot study, limiting enrollment to folks who don't have severe psychotic symptoms. But we don't know. We don't know why, because psilocybin does induce these transient, hours long hallucinations. But what we saw in the pilot study and what has been seen in trials outside of PD as well is that people seem to have these very intense hallucinations if they take a high dose of psilocybin, and then they do seem to resolve after about 6 hours and kind of come back to baseline. But it's something that we remain, aware that this is a risk in PD, and it's something that we are very mindful of, and we monitor hallucinations and other perceptual changes very closely in this study.
Okay, we're about out of time, so we have one more quick questions, which is what are the costs associated with this besides travel?
So we compensate people for their time in this study, and we can also cover a hotel for the in-person visits. So we've tried really hard to reduce the financial barriers to participating. You do not have to pay to participate in the study at all. We, like I said, we compensate people for each visit that they complete.
Great.
Yeah.
Thank you so very, very much. This was a
Of
fascinating topic.
course. Thank you so much for your attention, for having me, for great questions. Yep. It's fantastic. And I'll, you all will have my contact information, the information about the study. So, don't hesitate to reach out if we can answer any more questions.
Absolutely.
Yeah.
Thank you so much. So thank you all for joining us today. Today's event was made possible by our sponsors, Acadia and Boston Scientific. Thank you. We have some wonderful events coming up, which I'll tell you about in a moment. But if you enjoyed today's program, please visit PCLA.org and make your donation today. By donating to PCLA, you can join us in our mission to improve the lives of families in our community with living with Parkinson's. And you can find our contact information at the bottom of this screen. PCLA is a nonprofit and all donations are tax deductible. Our upcoming events are really great. Join us on February 27th for Moving Forward, practical tips to maintain independence and make life easier, Part 4. It's a catch up and wrap up with our wonderful guest OT, Dr. Mary Grace Lagoska. Watch for upcoming announcements for our annual LA 5 Marathon 5K charity walk, Saturday, March 15th. You can join the PCLA team at Dodger Stadium or have a personal virtual fundraiser from the comfort of your home. Of course, we'd love to see you there. Links to register for these events, as well as updates for all of our programs, will be sent out to our email list, or you can visit pcla.org. Thank you, everybody. Have a wonderful, wonderful day.
Thank you so much, Ellen. It was fantastic. So interesting. Thank you, Angela.